100 years and counting, until universal health insurance. Hello, my name is Karen Herman. Today I will be discussing the politics of health insurance in the United States. Today, many of us see health insurance as essential, whether you are in good health or not. In fact, we are all required to have health insurance as students at USC. During the early 1900s, the discussion of health insurance began in the US, but national health insurance faced much opposition. The major political concerns surrounding health insurance can be described in the four types of costs. Imagine a generic family in the 1900s. You have a husband, wife, and 4 children, all with regular living expenses such as rent, bills, and food. The husband is the sole source of income for the family. If he becomes ill and as a result unable to work, his family's life will deteriorate. Advocates for health insurance wanted to protect this family from losing their sole source of income. The second set of cost was due to the sheer medical expenses to the individual. Medical care for the general family was expensive, as it is expensive for most families today. Let's look back at our generic family during the 1920s. If the husband had an accident at work and sought medical care, how much would it cost? The family would pay the medical bills at the sacrifice of other things, such as food or clothing. There will be a breaking point from when medical bills exceed essential living expenses and the family could face poverty. Poverty leads us into the last 2 sets of costs. Third, the indirect cost of illness to society. Let's assume the worst for our generic family and say the cost of medical care forced them into poverty. This family would not be alone, as hundreds or even thousands of families could be forced into poverty due to serious medical illness. As a result, these families were no longer productive members of society, and poverty could lead to other family members becoming ill. Lastly, there is a social cost of medical care. The poor, including our family that were forced into poverty, the aging, and the disabled, were not working and could not afford any medical care. This group was vulnerable to more serious illness and death, and desperately needed some level of protection. Here is my question for the group. With national health insurance or universal health insurance being successful in other developed countries, what do you feel is the major opposition for adopting universal health insurance in the U.S. today?
Good morning, class. This is Hamad. Today I'm going to cover the period of post-war decade and the extension of the power of medical school into the hospital system of metropolitan areas. These medical schools, or sometimes called medical school empires, has a powerful position in the medical affair at that time, which gave the universities the power to be the umbrella organization for Americans' regional medical centers, which instead of being organized around the immediate need of patients, they were oriented primarily toward research and training. Due to this rise of medical schools, the medical profession had developed 3 different groups of physicians. The first group were the doctors who worked at the medical school and hospital, who were more in the training and research, and this group was far more significant group than it has been before the war, and it has no direct impact on patients' health stats due to their work as a researcher. The second group were the private group, who is primarily office-based practitioner. Even they had lost control of some medical institutions, they still have a privilege and dominant role in community hospitals. However, More of this group member were engaged in the specialty service. The third and final group were the doctor who work in rural and in near city area of a state institution, smallest in number, lowest in prestige. These were often older general practitioner or increasingly younger foreign medical graduates. They were the most professionally isolated of physicians. The contrast among physicians was only a reflection of contrast medical care system. Big institution with modern science that has the most advanced specialty services standing next to the neighbor that has been medically abandoned, that had no doctors for everyday need, and where the most elementary public health and the preventive care was frequently unavailable. The question that I would like to ask after reading this chapter: does the primary care physician has any control over all healthcare costs in the medical system?
Hello, my name is Jeremy Falkenberg, and today I'll be talking about the 5 structural changes that led to the further sovereignty of American medicine. Starr mentions the first of these as the emergence of an informal control system in medical practice that resulted from the growth of specializations and hospitals. The second was the control of labor markets in medical care. The primary means being licensing, requiring a medical doctor to obtain a license that came with a strict set of guidelines that he or she must complete before they are legally allowed to practice medicine. Another is a special dispensation from the burdens of hierarchy of the capitalist enterprise. This is essentially allowing physicians to use hospitals without paying a fee, or as they had previously done, paid this fee via providing free service with wards. The fourth was the elimination of countervailing power in medical care. In layman's terms, this said that no group or organization could offset the market power. Doctors were able to set their own prices based on what they felt the patient could pay, or perhaps what the regional market demanded. The fifth and final was the establishment of specific spheres of professional authority, meaning that the physician was the final authority on things related to patient care, while public health sectors could not go into the realm of private practice. These changes led to a dramatic sovereignty that physicians became almost untouchable. However, in recent history, we have seen a dramatic shift of hospital systems acquiring physician practices. There are many reasons to do so, including a dramatic decrease in overhead, where they no longer need their own credentialing staff or managed care professionals, but they are also losing that autonomy that they have fought so hard to secure. How could this impact the future sovereignty of physicians? Hello, my name is Jeremy Falkenberg, and this is my Power of 3 presentation coming from Starr, Chapter 2, discussing the changes in medical practices throughout the late 1800s. Perhaps the most significant change, and long-lasting, in fact one we still see today, was the implementation of fee-for-service schedules. There were 2 primary types of fee-for-service schedules. One established a minimum or a floor price. This price was used to prevent other practitioners from coming in and price cutting every other physician in town in order to get the most services. On the other end of the spectrum, we saw the implementation of schedules that contained a maximum price. These were established to help prevent price gouging. In the end, these fee-for-service schedules helped establish overall pricing methodologies that are akin to those that you might find on a restaurant menu. Another significant change was the ease of access for medical practitioners to become doctors. For starters, many practitioners did not even go to medical school. Instead, they earned their credentials through apprenticeships or from lecture series. For those that did choose to go to a medical school, the cost to do so was often significantly less than other career paths. For example, for someone starting out in the medical field, training, supplies, and everything they need could be found for less than $1,300. On the other side, if you wanted to go out west and establish a farm, this could often cost up to $2,000. In today's world, it's hard to imagine a scenario where doctors are in abundance and as a result find it difficult to obtain work. But this is exactly what happened in the late 1800s. With minimal training required, the low cost to entry, and the establishment of fee-for-service schedules to help reduce business overhead, too many people flocked into this profession. This would lead to a wide variety of issues and essentially chaos for the medical industry. Many of these problems will be resolved by the American Medical Association, as we will learn in future chapters. It has taken us over 100 years to realize that the fee-for-service schedule is not a sustainable model. It does not allow for physicians to differentiate themselves by charging based on the quality of their work. Instead, all physicians, those who excel and those who do not, are all paid the same. It does not protect patients as far as any kind of quality that they can expect. Some of these issues are being tackled by the Affordable Care Act, moving to other payment methods, including quality and pay for performance. But looking back, if we had never entered the world of fee schedules, how would modern medicine be different today if these fee schedules were never invented?
Good morning and welcome to 711 Health Politics class. I am Hamad, and today I'm going to cover the period of 1920 until the 1933, which include a little review in the Committee on the Cost of Medical Care and its findings. I will start a little earlier than 1920, where it was a push for a national health insurance proposed by the American Association for Labor Legislation and President Roosevelt's Progressive Party in 1915, which argued two objectives. First, eliminating sickness as cause for poverty by distributing individual wage loss and medical costs through insurance. The second objective was reducing the social cost of illness by providing effective medical care and to create financial incentive for disease prevention. Unfortunately, that proposal was defeated, especially when President Wilson won the presidential election in 1912, which indicate early end of such a progressive toward such reform. Even after the loss toward compulsory health insurance, the broad objective of health insurance continued to be relieving the economic problem of sickness. The focus of the reform shifted from stabilizing income and increased sufficiency to finance and expanding access to medical care. The shifting concern among American reformers from the wage loss of sickness to medical expenses reflected an objective change in the ratio of those two costs. Estimated in the late 1920s shows that medical costs were 85% higher than the lost earning due to sickness in the middle class population. The increase came in the cost of both physician services and hospital care. The cost of physician service rose because of both improved quality and increased monopoly power. And the rise of the hospital cost had its origin in the complete transformation of hospital care at the turn of the century. Besides the cost increase, there was a decrease on the number of physicians in the rural area due to the migration to cities and shrinkage in the medical school at that time. Now we have two major problems: cost and distribution of medical care, or organizational and financial problem. And here is what the Committee on the Cost of Medical Care exists, which a full independent, privately funded commission created by 15 economists, physicians, and public health specialists who meet in April 1926 and established the committee in the following year of 1927, which would comprehensively study the economists' healthcare over the following 5-year period. The number of the members of this committee has increased over time, and the committee studies were broadly in scope. They dealt with medical care needs, resource and expenses, professional and institutional investment. The final report was by 35 members out of the rest, organized into sections, detailing in the majority proposal along with several minority proposals. In general, the committee concluded that even among the highest income group, insufficient care is the rule, and the basic solution to this problem was to increase the amount of national resource going to medicine. The committee's major recommendations were quickly lost in the AMA negative publicity, instead of the thoughtful discussion of the different proposals. Even in the political view, the committee failed in its attempt to generate a new consensus for reform, but it gave more power to the physician who claimed that healthcare is a medical problem, not an economic problem. At the end of this presentation, I would like to ask the class whether they agree with the President Roosevelt idea of adopting a social insurance system to provide health care to the entire United States nation.
Hello, I'm Nora Al-Sharif, and I'll briefly be talking about the preparedness of the world's largest annual pilgrimage, Hajj, by the Saudi Arabia government. Between 2 and 3 million pilgrims from more than 183 countries make Hajj each year to Mecca in Saudi Arabia, which is a religious pilgrimage that every Muslim should undertake at least once in his lifetime. This represents an enormous organizational challenge in all aspects, especially the provision of healthcare within the Ministry of Health. Religious events and festivals can be attended by large numbers of pilgrims from within and outside the host country. One of the main public health concerns in relation to mass gatherings is the importation or exportation of infectious disease and spread between attendees and to the local population. The gathering of huge numbers of pilgrims can compromise the health system of the host countries. Moreover, the threat to global health security presented by infectious disease that might be exported to the pilgrim's home country shows the significance of advanced planning, global communication, public health surveillance, and response at religious mass gatherings. The Saudi government has a well-established system for the planning and administrative issues in relation to the Hajj. To minimize the health risk to the pilgrims, the Saudi Ministry of Health liaises with governments of all countries from which pilgrims visit Mecca. The public health measures for Hajj are focused on provision of safe water and food supplies, sanitation, vector control, pre-travel health regulation and advice about vaccinations, health checks, and specific immunization at the port of entry, health education campaigns, and provision of free health care to pilgrims through several clinics and hospitals. A proactive public health program is initiated before each Hajj, with focus on prevention of health hazards and healthcare provision during the pilgrimage. A multidisciplinary group of experts from various government sectors are involved in the advanced planning of health services, logistical support, and communication for the Hajj, along with continuous monitoring of emerging infectious disease. For instance, working together to control the Middle East respiratory syndrome coronavirus infection to not be transmitted to other pilgrims and avoid a worldwide epidemic. During Hajj, gastrointestinal infections are a major health hazard. Therefore, public health measures at the Hajj are focused on provision of safe water and food supplies, sanitation, and vector control. A Committee for Water Security Control does a daily inspection of the quality of drinking water to ensure that the chlorine pumping equipment function properly. Inspection of all main water supply sources and water tanks at various locations, including government departments and food stores in Mecca and the other holy sites, are done throughout the year. Furthermore, due to the warm, moist environment in Saudi Arabia, it is vulnerable to mosquitoes that are vectors for transmission of arboviruses and malaria. Therefore, a widespread vector control program is in action with routine and widespread pesticide spraying campaigns along the year. In Hajj, this program is intensified, and the Ministry of Health liaises closely with the Ministry of Public Health and Ministry of Agriculture to coordinate and assess pest control, identify the zones and density of mosquitoes, and undertake spraying campaigns. Specific teams spray housing units earmarked for pilgrims who come from dengue endemic areas such as India, Pakistan, and Bangladesh, with long-lasting pesticide before the arrival of the pilgrims. The teams also spray government departments and all field accommodation used by pilgrims, such as tents at holy sites, with a long-lasting pesticide. In accordance with the international health regulations, all aircraft and ship carriers are required to provide an official valid carrier sanitation certificate to verify the insecticide spraying was done before arrival at the port. These are only few examples of the huge efforts done by the Saudi governments and public health departments before, during, and after Hajj. Finally, here's a question for discussion. Have you heard about any epidemic that spread in a religious gathering? Do you think it's the public health efforts or it's something beyond that?
Hello, my name is Jared Bullard, and my Power 3 video today is on the modernization of American hospitals, what initiated these changes, and how they developed. One change that shifted hospitals into their modern state is the economic change that not only increased the prevalence of businesses and organizations, but completely restructured their internal makeup. Before 1870, hospitals were described as having a communal relationship with the patients who sought care there and the workers who provided the care. Care was mostly delivered through moral support. A communal relationship meant that these workers who facilitated and delivered care in hospitals were part of a community who lived and worked together. Starr painted a mental image of this relationship with the example of colonial almshouses. These houses were dedicated to members of society who were poor and homeless and had no other place to turn to meet their needs. These almshouses provided a place of refuge and existed as a safe haven. These houses met not only physical needs of society outcasts, but also met social and mental needs as well. The residents and workers of these early American colonial almshouses considered themselves as adopted families. This was also the case of early American hospitals, structured internally similar to colonial almshouses. The establishment of the first hospitals following these colonial almshouses were actually structured by remodeling and adding on to the existing almshouses and building larger institutions to handle a larger influx of people. However, the stereotype that stigmatized hospitals continued to prevail. It was a place where the poor and sick go to spend the last portion of their lives. Thus, a place of death and illness were strictly characterized of the early hospitals. Mortality rates were high following surgery, and it was extremely high when hospitals grew in size. It was far better for patients to seek care practiced in the home. The early development of hospitals were executed by physicians who were eager to have a place where the field and practice of medicine could gain reputation and public esteem. To do this, though, physicians needed the support of prominent members of society such as politicians, bankers, and lawyers to lend money and support in the execution of the idea. Therefore, these prominent individuals made up the governing board of early hospitals and had the final say-so in financial making decisions. Serving on boards in hospitals accompanied social prominence and status. After the Civil War, the development of organization and medical knowledge allowed for the modernization of hospitals to take flight. First, nursing became a field of professionalism by women of the upper class. These upper class women were dedicated to training women for the role of nurses to provide safe and effective care on the basis of hygiene. 3 nursing schools opened up in 1873 in New York, New Haven, and Boston. By 1910, these 3 nursing schools turned into 1,129. Also, surgery played a noteworthy role in this transition. Before, surgery was unsafe and resulted in fatalities due to the rate of infection. Also, before anesthesia, doctors had to work quickly, not focusing on quality, but instead on speed. The use of ether, as demonstrated by American dentist Dr. William Morton, quickly spread as an anesthetic technique to allow physicians to perform careful surgery. In addition, Joseph Lister's work on antisepsis sparked the need for sterilization to combat infection. Antisepsis, which is sterilization during surgery, was ineffective, so asepsis was introduced to sterilize surgical instruments before surgery. This facilitated the growth of surgery and brought it out of the homes and into hospitals. As surgery increased, the role of the hospital changed from providing moral support to providing acute care for the sick. This brought along cost issues by hospitals, which were solved by requiring payments from patients. The once dreaded image of hospitals morphed into a place for all classes of society. Also, the hospitals once controlled by upperclassmen of society was now focusing on those who delivered care the most, the physicians. The structure of hospitals changed significantly. Once composed of large open ward spaces, the new modern hospitals had private rooms in order to accommodate middle and upper class people and to accomplish their mission of acute care. However, there was a downside. With the growth of hospitals, access to its services were limited to certain populations of physicians. Many private physicians were cut off from gaining access into the hospitals to practice medicine. To combat this issue, groups of doctors opened small private hospitals to care for their patients. This was a way to teach larger hospitals that they needed physicians in order to continue to act in their new role. It worked. As a result of the competition from these private hospitals, larger hospitals opened its doors to more physicians. Secondly, physicians desired to tighten the organization of hospitals. Professional organizations, including the American College of Surgeons and the American Medical Association, published standards of organization of medical staff and hospital internships that hospitals needed to comply with in order for approval and support from these organizations. As the inclusion of doctors into hospital staff or affiliation grew and increased, other populations of society were left out, leaving an unorganized growth pattern of the hospital system. The hospital system developed into too many small hospitals with scattered scope and purpose. There were elite voluntary hospitals that focused on acute care and were closely tied to medical universities and treated both poor and middle and upper class citizens. The municipal and county hospitals cared for both acute and chronic conditions. These were public hospitals which relied on the government for financial stability. Lastly, there were religious and ethnic hospitals based on religious views and ethnic backgrounds. These included Jewish, Catholic, and Protestant hospital systems, as well as historically black hospitals and medical universities for the discriminated members of society. This resulted in a fragmented hospital system where care of all patients was not the primary focus. The hospital system today is still clearly fragmented. Although centralization of the modern hospital occurred in the 19th century by the help of the American College of Surgeons to develop a sense of organization and standardization of hospital systems, the many administrative tasks as needed to suffice this standardization prompted a need for more staff and administrative managers and executives. Therefore, the modern hospital is now broken into 3 entities: trustees or stakeholders of the hospital, administrators or executives, and lastly, physicians. It seems as if these 3 entities are competing for power. Hospitals have come a long way, but even today the modern hospital still has its challenges. Okay, I have 2 discussion questions. First, who do you think should have the final say-so in hospital administrative decisions? Stakeholders, administrators, or physicians? And secondly, how can we reach an alignment between 2 battling professions in hospitals, the executives and the physicians?
Hello, my name is Tony Brown, and today I'll be talking about George Rosen and his book entitled A History of Public Health. Origins of Public Health. In George Rosen's book, he exemplifies changes in medicine with a focus more on public health intervention even before its actual social construction. He details the great Greco-Roman architecture, the aqueduct, and how it was created for water filtration and sewage. Until the 19th century, medicine was based in divine judgment, abnormal mixtures of body fluids, and natural causes. Practitioners were using treatments like leeches to treat blood malfunctions, whereas now modern medicine deals with disease processes, locations of disease, symptoms, and causes. The actual burden of disease is finally being addressed. Essentially, at that time, man was treating the poisoned fruit instead of dealing with the poisonous tree that bear the fruit. Rosen gives an example to public health in the Middle Ages, where man started to be consistent with garbage disposal and sewage control. These areas in the Middle Ages were fortified by walls and moats, which would place man and animals extremely close. This gives rise to public health measures exceeding medicine and release from the burden of disease. After the 1850s, scientists like David Bruce, Ronald Ross, and Alphonse Lebanon began to study and reveal communicable diseases that were zoonotic, meaning derived from animals. As urban communities grew and sanitary conditions would deteriorate, it was evident that health reform was needed. One of the biggest achievements of the era was the Shattuck Report of 1850, which was published by the Massachusetts Sanitary Commission. Lemuel Shattuck was a publisher and teacher who saw a need for accurate vital statistics. Through the report, we could finally start to see the actual burden of disease in infant maternal mortality, communicable diseases, and subpar living conditions. George Rosen gives us a great overview of the development of public health and of medicine. The question I'd like to ask is, what shaped the development and perception of medicine more? Is it the development of medicine itself, or the necessary construction of public health?
Good morning, class. I'm Hamad, and today I will talk about the lack of public health and fast political action involvement in controlling and infection disease, using the 1980 Spanish flu as an example of less political and public health involvement. However, nowadays Ebola pandemic is receiving great political and public health involvement, which lead, as you may feel, to better control of deadly infection disease. Let's begin with the Spanish flu. The Spanish influenza pandemic of 1980 was the mother of all pandemics. Nearly 500 million people were infected with the flu, resulting in an estimate of 675,000 American dead and 50 million worldwide. Those numbers is more than the total death of the First World War and equal to 3% of the world population at that time. It called the Spanish flu because the pandemic received great generalist attention in Spain than the rest of the world, because Spain was not involved in the World War I and was the first to report the pandemic. The outbreak began in the United States is when the soldiers came back from the war. So in spring of 1980, there was a few cases reported. But in March 30th, 1980, the occurrence of 18 cases of influenza of severe type were reported, which killed 3 soldiers, and that was reported at Haskell, Kansas, which later on considered the ground zero for 1980 pandemic in the United States. Over the following 6 months, the number of cases increased, and the influenza became a national health threat. Soldiers' movement to other camps and to their family was a great factor of spreading the disease, and the country itself at that time were under the war, so people or the politicals were really attention to what's going on in the war, which lead to little data existed to indicate any sizable spread among the civilian population, beside what is going on in Europe or in the World War. People were encouraged to wear a mask and avoid spitting in public. By the 1990s, hundreds of thousands of American citizens had died, and millions worldwide. As what we saw in this clip, there was not much attention to the Spanish flu, maybe because of the war, and that led to many deaths at that time. But nowadays Ebola infection is receiving great attention. Even the country is involved in a new war. I mean the Middle East conflict. My question is this: do you guys think the handling of the Spanish flu back in 1919 was an appropriate handling of an infection disease at the country level at that time?
We made it both through Passchendaele, the Somme and Flanders too. But now my number's up, my lad, for I've gone and caught the flu. It was the flu pandemic, and it swept the whole world wide. It caught soldiers and civilians, and they died. Whether lying in the trenches or lying in their beds, 20 million of them got it, and they're dead.
Hello everyone, I'm Kim Ye, and today I'd like to present you about safe motherhood challenges in Myanmar Burma from social determinants of health perspectives. Women in Myanmar face high maternal mortality ratio and low reproductive health awareness as a result of challenges in social determinants of health. Maternal mortality ratio of Myanmar is 240 per 100,000 live births and 600 in conflict-affected rural remote areas. Neighboring countries, Thailand has maternal mortality ratio of 44 per 100,000 live births, and Sri Lanka has 35 per 100,000 live births maternal mortality ratio. In the rural remote areas of Myanmar, midwives are main healthcare providers and free frontiers with work overloads and very low salary, $35 per month. National health system does not provide transportation facilities when midwife goes to the community for outreach, maternal and child health services. They have to take risks among armed conflicts and landmines in conflict-affected areas. Therefore, enabling environment is critically needed for healthcare providers in Myanmar. In the rural remote areas of Myanmar, the road conditions are very terrible. The farthest distance is 3 days on foot travel from villages to rural health center. In the hilly regions, there are landslides during rainy season. As a result of difficult transportation, midwives and communities cannot reach each other. Communities deliver with village traditional birth attendants instead of midwives. Therefore, there is low prevalence of skilled birth attendant delivery, which is indicator of UN Millennium Development Goal 5. In unconflict-affected areas of Myanmar, communities could not come to seek health services at rural health center whenever they need, since they have to be very cautious of artillery shelling and landmines. Midwives could not also attend home deliveries every time. Communities from rural remote areas are still practicing unhealthy taboo traditions and customs. In very poor mountainous village of eastern part of Burma, communities still practicing unhealthy taboos. Newborns have to take baths with very warm water 9 times on day 1, 8 times on day 2, till reaching 1 time per day. In one community, postpartum women, that is women after childbirth, practice putting warm bricks on her belly for uterine evolution. In few areas, communities believe that it is unlucky if they accept pregnant women from another village for childbirth, and as compensation, they charge 1 pig or equivalent cash for her childbirth at their village. Some pregnant women are still reluctant to come and deliver at rural health center because they get ashamed that their poor utensils will be seen by other villagers when they come to encourage and give blessing to the newborn baby. For these customs and taboos, communities prefer to deliver at home with traditional birth attendants. If we look into country socio-economic status, Myanmar is low-income country with low Human Development Index, 150 out of 187 countries. 70% of country's total population reside in rural areas where there are poor infrastructure and resources. The majority of population has livelihood and financial hardship. When pregnant women deliver at rural health center, she might need one of her family members to attend her delivery, and that person cannot walk while attending her. If she delivers at home, the attendant still can do home-based, small farm, or household chores. If we study National Health Policy of Myanmar, WHO reported that non-accessibility to healthcare services in Myanmar is associated with socio-economic status, location, and availability of services. 80% of health expenditure is out of pocket. Government health expenditure is less than 2% of GDP, whereas 20% used in defense. WHO designated that Myanmar is one of 57 countries facing a severe health workforce crisis, with only 1.3 health workers, doctor, nurse, and midwives per 1,000 population. Prioritized policy reforms of Myanmar Ministry of Health are human resources for health strategy, increasing government health expenditure, innovative measures for reducing out-of-pocket expenditure that includes a voucher system for maternal and child health, and free essential medicines for all. At 65th World Health Assembly, Myanmar Health Minister stated that universal healthcare is not a one-size-fits-all concept, and that countries will travel different paths towards universal coverage depending on where and how they start. As recognition of policy reform in Myanmar, international community has gradually lifted sanctions against Myanmar. Donor organizations and funding agencies should continue their emphasis on maternal and child health. The social determinants of maternal health in Myanmar are quite perplexing and challenging, since they are concerned with health implications of socio-economic policies, as well as the benefits of health investment. However, considering and including social determinants of health in every health policy development will definitely bring health equity and social justice. Here, my discussion question is, what policy interventions will be effective, low-cost strategies to reduce maternal mortality ratio in Myanmar? Thank you.
American politics has wrestled with the idea of national or compulsory health insurance since the early 20th century. 3 major campaigns to establish national health insurance failed. In the 1910s, the 1930s with the New Deal, and the 1940s with the Fair Deal. This video by Emily Zimmerman will look at the struggle for national health insurance, who has opposed it, and why. Starr notes that in the 20th century, the medical profession became powerful, prestigious, and wealthy, and shaped the basic organizational and financial structure of American medicine. Throughout the 20th century, this meant limiting competition and fiercely guarding professional sovereignty, including opposing any intermediaries that might take decision-making out of the hands of doctors. On the eve of World War I, progressive reformers were campaigning for health insurance reform, after nearly all European countries had adopted a health program, and following the successes of workmen's compensation laws in the U.S. The American Association for Labor Legislation proposed a health insurance bill in 1915, focused on the needs of the working class. Commercial health insurance was undeveloped at the time, but powerful insurers were on the scene to oppose any imposition on their market, such as burial insurance. Business and labor were not supportive, and physicians became increasingly opposed. With World War I, the idea was linked with socialism and died away. In the 1930s, healthcare costs were a growing concern. New Deal ideas called for state-run compulsory health insurance. Yet, facing the Great Depression, President Roosevelt's Committee on Economic Security faced the fact that unemployment was a higher priority than health insurance. Despite large Democratic majorities in Congress, health insurance was put on hold to assure success of the Social Security Act. There was a fierce opponent in the American Medical Association and continued lack of support from labor and business. In the 1940s, President Truman championed a national health program under a single federal system with subsidies for the poor, but political forces were too powerful to let reform succeed. Employers were now providing private health insurance for many workers, and unions felt they could negotiate benefits themselves. The AMA called Truman's plan socialized medicine, while many interest groups supported private insurance. Opponents of national health insurance waged an ideological war against it, while they generally sought to retain control and limit any governmental interference. The public generally supported increasing access to health care and making coverage universal, but wasn't enthusiastic about sharing in the costs, and often felt private insurance could do the job. Despite fierce opposition to the Affordable Care Act, access to health insurance has increased for many Americans. My question is, why did so many healthcare providers oppose the ACA, and has the ACA actually helped or hurt them?